Hello, this is Kay Afji. We are taping the lecture for nursing care of patients who have upper GI disorders. The first thing we'll talk about is stomatitis. Stomatitis is an inflammation of the mucous membranes. Causes of stomatitis are trauma from ill-fitting dentures, poor oral hygiene, and in some cases nutritional deficiencies. Treatment of stomatitis is special mouth care, perhaps with a special type of, say, mouthwash that does not include alcohol base, also artificial saliva, and a particular diet. So if a patient has a sore mouth, maybe you put them on a soft diet, something that's easy to chew with ground meat. Then we'll look at dysphagia, which is known as difficulty swallowing. Causes can be from tumors, inflammation, motility disorders, from neurological problems. People who have strokes may lose the ability to swallow. People who have dementia, late stage dementia, have difficulty swallowing. The treatment for dysphagia depends on how severe it is. If the patient is not able to take any oral intake without choking or aspirating, they may be placed on an NPO status and then fed via a feeding tube. How do we determine how severe the dysphagia is? Usually speech therapy will come in and do a swallowing assessment, and then a video fluoroscopy can be done to diagnose if the patient has dysphagia and how severe it is. If they aspirate on thin liquids, then maybe they would be put on a thicker liquid type of diet. If you're taking care of someone who has a problem with swallowing, of course, you're going to make sure that, first of all, that if they have a diet restriction as far as how thin the liquids can be, that is followed to a T, so that we don't risk the patient aspirating or developing pneumonia. In some cases, you just have the patient take some practice swallows before they're going to be eating. Maybe that helps them with their swallowing. Again, know what consistency of food the patient can tolerate. If they're able to have fluids, have the patient take a small amount of fluids throughout the meal. That kind of moistens the GI tract and makes the swallowing a little bit easier. If not, of course, then thickened fluids is necessary. Have them sit upright as much as possible when they're eating, and in some instances, tucking the chin in toward the chest helps with the swallowing as well. So you might want to take that into consideration when you're feeding a patient who has a swallowing issue. Aspiration from dysphagia may result in pneumonia. If you have someone who has some swallowing problems but still can eat, make sure that their suctioning equipment is available. And if, like I say, unable to swallow, the patient would then have a gastrostomy tube placed so that they can have liquid feedings directly into their stomach or their jejunum. The next problem we're going to look at is hiatal hernia. The hiatal hernia is a protrusion of the lower esophagus and stomach up through the diaphragm and into the chest. Causes of this condition are weakness of diaphragm muscles where the esophagus and the stomach join. The exact cause of it may not necessarily be known, but factors that can contribute to hiatal hernia are excessive intra-abdominal pressure, maybe due to trauma or long-term bed rest in a reclining position, so the stomach can migrate up through the diaphragm. Signs and symptoms of hiatal hernia are, in some cases they may not necessarily have symptoms at all. Others report feelings of fullness or inability to swallow. They may have frequent belching or burping. They may have problems with regurgitation, or they may have complaints of heartburn. The example or picture that you see on your screen now is that of a Nissen fundoplication, which is a treatment for hiatal hernia or hiatal hernia repair. What they do is bring the hernia down below the diaphragm, and then they will take a portion of the upper part of the stomach and wrap it around the esophagus and suture it in place, and that prevents the stomach then from migrating up through that opening again and keeps the hiatal hernia from reoccurring. Treatment other than surgery of a hiatal hernia, of course, would be to reduce weight, avoid tight-fitting clothes around the abdomen, take antacids, histamine receptor antagonists, and proton pump inhibitors, because that will bring down the discomfort with gastric esophageal reflux that goes along with hiatal hernias at times. And then elevate the head of the bed on 6 to 8 inch blocks to prevent the patient from laying completely flat at night. Teach ways to prevent pain and reflux. Encourage weight reduction. Remind the patient to stay upright for 2 hours after eating and not to eat for 3 hours before bedtime. That prevents, again, the reflux from going up into the hiatal hernia area. If the head of the bed cannot be raised, there's a wedge pillow that can be used to elevate the upper body. This position helps prevent reflux and assists gravity in maintaining the stomach in the abdominal cavity. And then avoid foods that cause bloating. It also will decrease the pain with the hiatal hernia. Then we have gastroesophageal reflux disease. This is where there's a backflow of gastric contents from the stomach into the esophagus. It's caused by abnormalities around the lower esophageal sphincter. It also can be related to gastric or duodenal ulcers, gastric or esophageal surgery. It can result from prolonged vomiting or prolonged gastric intubation. So if the patient has an NG tube, it can cause GERD. Signs and symptoms are painful burning sensation that moves up and down the esophagus, commonly occurs after meals, and is relieved by antacids. Medical diagnosis is often treated just based on signs and symptoms, but can be diagnosed by visualization directly during an upper endoscopy. A biopsy can be obtained. They can do a gastric analysis to see about the acidity of the gastric secretions. 24-hour monitoring of esophageal pH or acid perfusion tests. The medical treatment is similar to that of hiatal hernia. Again, drug therapy can include H2 receptor blockers, prokinetic agents, and proton pump inhibitors. If medical care is unsuccessful, then a surgical Nissen fundoplication would be done. Okay, as far as nursing management goes, we would encourage them to avoid high fat, oils, and spicy foods that may exacerbate the symptoms. Eat 4 to 6 small meals a day. Eat slowly and chew food thoroughly. Avoid using straws for liquids. Avoid carbonated beverages. Limit alcohol, tomato-based products, caffeine, citrus juice, chocolate, coffee, peppermint, and spearmint from the diet, because that can cause more acidity in the stomach. Wait 2 to 3 hours after eating before lying down. Do not wear clothes that constrict around the middle of the body. We encourage weight loss, sleeping with the head of bed elevated 6 to 8 inches, taking medications as directed to stop smoking if they're smoking, and then exercise regularly to help reduce stress. Complications of GERD are Constant irritation may cause cellular changes such as precancerous lesions, which could then lead to cancer of the esophagus. Patients also may be at risk for aspirating the reflux and then resulting in pneumonia. Okay, peptic ulcers. Pathophysiology is that there's a loss of tissue from the lining of the GI tract or digestive tract. They can be classified as either gastric or duodenal depending upon the location. Common causes are drugs such as, or frequent intake of drugs such as NSAIDs, infection from H. pylori, and also stress. Most ulcers are caused by the microorganism H. pylori that has an enzyme within it that can corrode the stomach lining. It doesn't really do anything to increase the acidity of the gastric secretions, but as I said, the enzyme that occurs in H. pylori erodes the stomach lining. They also found that smoking contributes to the formation of peptic ulcers. Gastric ulcers also can most often occur in men more than women and in older adults. Here's a picture of how the gastric juices, excessive amounts of gastric juices are released into the stomach, and that also will, filter into or go into those areas of breakdown of the lining of the stomach, forming an ulcer because the H. pylori has already started breaking down the lining. And then the gastric juices, the high acidity, definitely doesn't help the situation. You can also see in this picture that the difference between like a duodenal ulcer, which is after the pyloric sphincter and into the small intestines, as opposed to a gastric ulcer that is located within the stomach area. Okay, oops. So, signs and symptoms of peptic ulcer: we have burning pain. Pain is less in the morning when there's less gastric secretions in the stomach, and it's most severe before meals and at bedtime when the stomach is empty. So, and then they also may complain of nausea, anorexia, and weight loss. If it becomes severe enough, the acid and H. pylori can actually erode through the stomach lining and could actually erode through a blood vessel, which could cause gastric bleeding or GI bleeding. The medical treatment is, let's see here, drug therapy, again, and diet therapy, and then managing complications if they occur. Drug therapy is intended to relieve symptoms and heal the ulcer, cure the H. pylori infections, and prevent reoccurrence. The patient can actually have almost any foods that do not produce discomfort, so there's not a specific diet that they have to follow. The complications that occur can be treated either medically or surgically. If hemorrhage is suspected, a nasogastric tube is inserted and attached to suction to remove and measure blood in the stomach. If the patient experiences hematemesis, which is bloody emesis, that bright red blood would indicate an active bleed. A coffee ground emesis would more indicate an older bleed, maybe not active any longer. Treatments are antacids, gastric bleeding, and normal saline lavage can be done where the NG is placed, and then ice saline is instilled into an NG and then brought back, withdrawn, to try and irrigate that area. They may be started on H2 receptor antagonists and proton pump inhibitors. If there's a presence of H. pylori, they will be started on clarithromycin, plus probably another antibiotic, an H2 inhibitor, and a proton pump inhibitor to treat that infection and help heal the ulcer. So complications, as we talked about, the hemorrhage is one where the ulcer erodes into the blood vessels and bleeding occurs into the stomach. Perforation occurs when the ulcer erodes the stomach wall and contents of the GI tract spill into the peritoneal cavity, and that can cause peritonitis. Or in some cases, obstruction can happen as a result of scarring at the pylorus because of the constant irritation and the healing over of that area. The pylorus becomes scarred, and then it prevents gastric emptying. So that would result in an obstruction. What kind of surgical treatment can be done? A pyloroplasty with truncal or proximal gastric vagotomy. So the pyloroplasty would be the opening of the scarred pylorus. So they would make an incision, widen that area, and then they would sew up the incision. They also at that time will decide where they want to cut the vagus nerve to prevent any more excess secretion of acids into the stomach. The subtotal gastrectomy or gastric resection can be done where they take a portion of the stomach that maybe there's bleeding occurring, and then they'll suture up the stomach. Or they may have to do a total gastrectomy where the whole stomach is removed and the esophagus is then attached to the small intestines. With a total gastrectomy, we have to restrict their feedings to small, frequent amounts that are easily digested, mostly semi-solid. Also remember that oral medications may not be as effective because of the altered absorption. They're not going to be, ingested and broken down like they normally would. With a subtotal gastrectomy, the patient is started on small amounts of liquid to tolerance, and then their diet actually is increased to what they can tolerate. The stomach eventually will stretch out a little bit, so they'll be able to eventually take 3 regular meals a day. With a total gastrectomy, they're at risk for experiencing a dumping syndrome. That is a rapid passage of large amounts of food and liquid into the jejunum due to the removal of a portion or all of the stomach. Signs are nausea, abdominal pain. The patient feels faint, they perspire profusely, and they experience palpitations. To prevent the dumping syndrome from occurring, we need to teach the patient to avoid eating large meals, to minimize fluids during the meal, but instead take fluids in small amounts between meals and avoid sugary foods. And here's a picture that just demonstrates on the top we have the surgery, that's the pyloroplasty, where they open up the area of the pylorus because it's been scarred over, and they also cut the vagus nerve that goes to the stomach to prevent increased secretions of acid. And then on the bottom you see a normal anatomy of a stomach and the small intestines, the duodenum. In the middle you see where a partial part of the stomach has been removed, so it's a subtotal gastrectomy procedure. And different procedures like the Billroth 1 and the Billroth 2, I wouldn't expect you to determine between the two, but just so you understand what the subtotal gastrectomy is, where part of the stomach is removed and the rest is attached from the esophagus, the stomach, then attached to the duodenum. And then way on the right hand side you have what's a total gastrectomy, where the entire stomach is removed and the esophagus is attached then to the jejunum. And here's just a little cartoon to help you just to remember the dumping syndrome. It usually occurs 15 to 30 minutes after eating. They experience gastric fullness, weakness, dizziness, vertigo, diaphoresis, tachycardia, abdominal cramping. The condition eventually is self-limiting, but it's very uncomfortable for patients when they're experiencing it. So again, we encourage no fluids with meals, no high-carb foods, no sugary foods, that type of thing, and that helps to prevent the dumping syndrome. Also, we may have the patient lie down flat for 30 minutes after a meal as well, and that sometimes will help prevent the dumping syndrome. Common therapies for disorders of the upper GI system: gastrointestinal decompression, where we insert the NG, place it to low intermittent suction to remove fluids from the stomach, especially done like if there's an obstruction and the fluids aren't able to pass through the GI tract as normal. They accumulate in the stomach. Patient experiences nausea and vomiting, so we place an NG in to decompress the GI system, get those secretions out, and then until the obstruction either resolves itself or they remove it via surgery. Another thing that we do to treat GI problems, enteral nutrition, which is done via feeding tube. There are various routes that we can use. We can do a nasogastric tube, place it through the nares and down into the stomach. That we usually do if it's just a short-term type of condition. If the patient's going to permanently be on tube feedings, then we usually will place a gastrostomy tube where the gastroenterologist will make a incision into the abdominal wall and then place a feeding tube through that little puncture area into the stomach. That's percutaneous endoscopic gastrostomy tube, so they place that using the upper endoscopy. There are other types of tubes like a percutaneous endoscopic jejunostomy tube, which is a smaller tube that goes just not only through the stomach but is placed then into the jejunum. This one is kind of nice because you don't have to worry quite as much about aspiration because of the placement of the tube. It's in the intestines. With a tube feeding, usually when you're instilling the tube feeding, of course you're going to have your patient sitting up to prevent aspiration. Before you start a tube feeding, you're going to check the residual to make sure that there's not a large amount of tube feeding sitting in the patient's stomach, because if it's not moving through and you put more in, the patient's going to have an emesis and then aspirate. So you need to check the facility's policy and procedure as to when checking the residual, how much residual would put their tube feeding on hold, when would you contact the healthcare provider regarding the amount of residual that's still sitting in the stomach, that type of thing. And then we have total parenteral nutrition, otherwise known as TPN. This is when the patient solely gets all of their nutrition via their IV solution. The IV solution is extremely viscous because it's a high dextrose solution, and they also get lipids IV, which also of course is much more viscous. So that's why we need to use a central line to administer TPN, because a peripheral vein is never going to be able to handle that high of a viscous solution. Again, we try to avoid using this if the patient's gut is working at all and it's just a matter of they can't swallow. We would of course use a feeding tube. If we have the patient completely NPO, especially for extended periods of time, you're going to find that the bacteria that lives in the GI tract is going to start diminishing, and then we're going to have complications because of breakdown of the intestines and things like that. So, using a TPN solution is probably our last resort, because we always want to use the gut if it's functioning. As far as TPN goes, a patient needs to be kind of weaned into having TPN. It's not started at a high rate. It's started at a slow rate, and then slowly the rates are increased, so the circulatory system can develop like a tolerance, let's say, to the solution. Oftentimes we'll be checking the patient's blood glucose at least every 6 hours initially to make sure that they're able to tolerate that high dextrose solution. If not, you may find that there's insulin added to their TPN. Because the solution again has such a high amount of sugar to it, the solution is at high risk for contamination, so you really need to make sure that you're using aseptic technique, not only when you're spiking the solutions, but also when you're changing the dressings to that central line, because any kind of bacteria is definitely going to be able to grow in that solution, and the solution infuses directly into the patient's bloodstream, so it could cause them a lot of problems if the sterile technique is not followed. That's the end of this lecture on the nursing care of patients with upper GI disorders.